Morning. Thank you to the organizers for inviting me here and hope Dr. Mishra gets better soon. This is a mini case presentation on a little unique case of type A dissection. So before it starts, I would just like to tell you, I get a lot of references to do endovascular management for type A dissection, but we still don't have the right endovascular treatment for it. And a lot of them have obviously been previously treated because it's an emergency and the treatment has been done, but then the arch starts expanding, the descending thoracic expands, and then we normally need to go in for a redo surgery which has to be done, and that adds to the morbidity. So this is a case which I'm going to show you. It's done by two of us, myself and Dr. Behranwala. So just for type A dissections, we all know it's morbid and got a high surgical mortality. But the issue is once the type A is treated by just replacing the ascending aorta, there is associated rates of false lumen patency, which actually expands in the descending thoracic aorta, and the arch do expand. And then it leads to formation of complex arch and thoracoabdominal dissecting aneurysms. And that is the core issue here. How do we treat this once it's already been opened up and already been done? Then to go in and do the whole procedure again has its issues. So the standard procedures which are normally done, which I normally see, which are referred is basically an ascending aortic repair with or without the hemiarch. The great vessels are close to the dissecting part in the arch, or you do a Bental, and there's a very infrequent use of the elephant trunk procedure. So there is issue of false lumen expansion, true lumen compression, visceral ischemia and limb ischemia which can occur once the ascending aorta is treated. Then how do we treat this? So there are improved surgical techniques. I was going through literature. There is something called branch first arch replacement, which is a very interesting technique with total aortic repair. And then when required, you can safely do an endovascular procedure to bridge the thoracoabdominal, the thoracic segment. Or you do the frozen elephant trunk procedure, or at times even do the David's procedure. So I'll just quickly go to the case since we are lack of time. So this was a 60-year-old lady, hypertensive, presented with severe chest pain and hypotension, but no visceral or limb symptoms. Urgent 2D echo showed an acute AR with a dissecting flap in the ascending aorta, and a CT angiogram showed a Stanford type A dissection going all the way down to the bifurcation. The great vessels were from the true lumen. The celiac SMA were from the true lumen, and the renals were partially from true and false. The root was not involved, and this lady underwent an urgent surgery where the surgeon did a David's procedure with aortic valve repair with ascending aortic replacement and coronary reimplantation. So we got the CT done after the procedure. The surgery was pretty uneventful, and there was no AR post surgery, but the follow-up CT angiogram showed a thoracic false lumen expansion. So it became more dilated, going to nearly 4.5 to 5 centimeters. And the patient's true lumen started compressing, and she started presenting with early claudication. So we thought that the ideal treatment is now again do an ascending bicarotid repair, because there was no place for me to land the graft in the arch, because this was dissected here, as you can see on the arrow here, and I would have to compromise it. So that would be a resurgery by doing aorto bicarotid repair with a subclavian bypass, and that would add to the morbidity of the procedure. So this is something which we did. It's one, I would say, I tried to go through the literature. There is no case reports done in the world. So this, I presume, should be the first case which we have done. Is what we did here was we went inside and we went through the true lumen. We went into the graft, as you can see here. Then we took a standard thoracic graft, an endovascular graft. This is the Cook Zenith graft which I used. And ideally, I was planning to cover the left subclavian artery. As you can see here, keep it from the left carotid, and then just deploy it there, because that was a relatively little healthy portion. But then I realized that we need it in case for any future treatment, I need the subclavian patent. So it is kept distal to just at the level of the left subclavian artery. And what we did in this case was, we used the Zenith dissection endovascular stent to bridge the arch. So these, just for your knowledge, these are the stacked bare Z stents which are sutured by polypropylene sutures. They come in two sizes right now, the 36 and 46 mm, with various lengths, as you can see here. What is the basis? This was actually used in this, when we used to use it for type B dissections, to keep the true lumen patent and to prevent visceral malperfusion. So I sort of use this stent in a different manner, sort of off-label use, to use it, where this basically is large open stent structure, so the branch vessels can be perfused, and it also allows the dissection flap to slowly close or close, and it allows the re-expansion of the true lumen, which will help to prevent further dissection going down and prevent aneurysms. So this is how it looks. You can see this arrow which I'm showing here. So this is the stent, a large stent to the abdominal layer, the thoracic graft which is here. So this is how it looks. So you can see it's basically metal coming in from all the way from the graft across the arch and going into the endovascular graft which is there. So, and we took a final run, you can see that there is a little stabilization of, you can see still a little false lumen filling here, but that will definitely stabilize over a period of time. And most importantly, the true lumen has shown good expansion and the false lumen has nearly thrombosed all the way to this level. And that is what we wanted to achieve in this lady. And we got a follow-up CTA after 3 months. So this is just the initial phase. This CT was done just around a week to 10 days back. And we got a stable arch. There is no expansion of there. The true lumen is well expanded. Her claudican symptoms have definitely disappeared. We got a false lumen which is thrombosed till D7 level. All the arch vessels are patent and the thoracoabdominal segment is stable. Why I have used the bare stent in this is because in case I want to further treat the thoracoabdominal segment and I need access through the left subclavian or sometimes even through the left carotid, then I still have access. I can get wires through. As you can see in this picture here, I could get a wire through very easily from the brachial, come inside through that strut. So I have no issues of getting access through and coming down. And the advantages is that the branch vessels are patent. There is access possible for future interventions. But there obviously this is a new procedure. I will not know how this responds in the arch for a long term. So luckily this lady is an extremely good follow-up patient. So I am going to get a good follow-up. Maybe I've advised her a CT scan again after another 6 months to a year, and then yearly CT scans to see how the arch will behave. And there are issues of a bare stent in the arch which can lead to thrombus formation, which can go up. So I have kept her, there is no data, so I've kept her on a single antiplatelet and even a low-dose warfarin right now. There is no reported case which is there, and there are long-term results awaited, and would love to see your opinion of these renowned cardiac surgeons here, if this is one of the options we could consider for treating this complex procedure. Thank you.